Hey guys, this is Elliot Fishman and welcome to Facebook Live. And I took my mask off. I can see this thing tracks me a little bit, but a little late that is. So I have, I think, about a dozen cases or so. So without any ado, let's get started. So the first couple cases, I'll make it easy for you. I'm telling you they're adrenal lesions. So here's a patient with right upper quadrant pain. And you see a mass in the region of the adrenal. Obviously, it could be kidney if I was trying to trick you, but I'm not trying to trick you. So what are you looking at? You're looking at a large cystic lesion. There's some higher density zones within it, perhaps, or maybe potentially even some enhancement. This does have IV contrast. Here's another look at it. With the coronal view, you can see cystic, fairly large, compressing the right kidney. What do you think? Well, whenever I see some high density, I always got to think about blood. Surely I can't be saying this is a solid tumor, right? So we got to go and think about what things give you cystic lesions. Obviously simple cysts, but with simple cysts you would not have septations or some of the higher density. You can have something that bled, cystic pheochromocytoma, primary adrenal cortical carcinomas can bleed. You also can have other things like myelolipomas which can bleed. I don't see any fat here, but if this was blood, you can obscure the presence of fat. There are several unusual adrenal lesions which can be low density. Lymphangiomas, ganglioneuromas are in the differential. The thing is, in my heart, and probably your heart as well, you got a feeling this is benign, but it's not a leave-alone lesion. It would be something that would be taken out laparoscopically. So my question is, what is it? Time's up. It was an intra-adrenal ganglioneuroma. They're unusual tumors. They do occur. They're benign. The pathologist did see a little bit of hemorrhage. Maybe that explains the higher density zones. It also explains why the patient presented with symptoms of right upper quadrant pain. Usually these lesions are incidental findings. Same thing with lymphangiomas. Okay. That was a great case. Now let me give you another case. Patient with back pain. What are we dealing with here? Well, you can see there's a large mass in the left adrenal. There's areas of enhancement. There's areas of what look like punctate calcifications. Now you think about large adrenal lesions, what are you thinking about? Well, there could be a number of possible things to think about, but you gotta really consider primary adrenal cortical carcinoma. You can have metastasis, hepatoma, and melanoma give very large mets. They could be unilateral. Pheochromocytomas are very vascular typically, though they can be cystic. They can be large, but I'm not really thinking about a pheo in this case. This looks something malignant. Again, solid. You can have strange tumors that can be solid, but I gotta be thinking malignancy. Here it is again. There's some neovascularity in the lesion. And if you look really hard, you see this neovascularity in the liver. And that's the good hint, right? Well, maybe you have a primary adrenal cortical carcinoma metastatic to liver, but probably more likely when you think about it, you better think, I'll give you 5 seconds, you're thinking, and hopefully you were thinking that this was hepatoma that explains the neovascularity metastatic to the adrenal gland. What a terrific case. And for whatever reason, melanoma and hepatoma give the largest unilateral adrenal masses. If I have very large adrenal masses, and even unilateral, I would also consider lymphoma. So that would be another possibility. Okay, let's go to another patient. And now I'm giving you another mass, left upper quadrant. Not quite as big as the last one, but pretty close. But it's solid, but it's not enhancing. You don't have that same vascularity as you saw in the other case. But again, the contralateral right adrenal looks okay. What am I dealing with? ACC is a possibility. Pheo, okay. Metastasis, okay. But I'm thinking, I gotta be thinking of a solid mass. There it is again, kind of oval shape. I don't see much else in the abdomen. Everything else looks good. So you got a feeling it's solid. I'm worried about malignancy. Well, what does this end up? Give you 5 seconds to think. Remember I said before, big masses, I think Mets, I think ACC, and yes, although I prefer bilateral, I could think unilateral lymphoma. And this wasn't very vascular, and this was a primary B-cell adrenal lymphoma. Just a terrific case. Remember, adrenals often maintain their triangular shape with lymphoma. Often, or most often, it's bilateral, and it can be very large. This case was unique. It was oval, and it was unilateral. What a great case. Okay, let's keep going. I'll give you another one. Wow, here it's hard to tell where the masses are rising, but those of you who come to my quiz and are allowed in, you know that when I put something in the adrenal section, it's not by accident. So you could say retroperitoneal sarcoma, good thought. Really big mass off the pancreas, not a great thought, but a reasonable thought. Maybe a big renal mass. But you also have to consider, what about adrenal? Well, if this mass is adrenal, and the coronal view, again, we love coronals. Coronals kind of tell you this is adrenal. What adrenal lesion has calcification, vascularity, and necrosis? You could consider a Met, but the Mets typically don't calcify. The modeled appearance, everything was seeing. Here's some more images with 3D showing you the large mass, the varied enhancement. Everything you put together takes you right to the diagnosis of a primary adrenal cortical carcinoma. Just really a great case. Okay, looks like I'm really sticking with the adrenal in this series. Another patient, right upper quadrant pain. Big solid mass, maybe there's some cystic components. This is the non-contrast. Here it is with contrast. Lower density cystic, but a large mass. ACC possible. Cystic Mets, I guess it's possible. Lymphoma should not be cystic like this. That's less likely. But I gotta think of something. What has given me a large, well-defined solid tumor? I showed you a few cases, so I want to show you the whole spectrum. I showed you Mets, it's a possibility. I showed you ACC, it's a possibility. But lymphoma, I just don't like it, but I guess it could be. Well, what did this end up being? Pheochromocytoma. Pheos can be large, they can be cystic, they can be vascular. This lesion had a little of everything. And although we like to see pheos 3 to 5 centimeters hypervascular, very good washout, enhancing to about 150 to 170, pheos can also be seen as relatively hypovascular, can be seen as cystic. There's lots of different possibilities. So I'm going, and this answer was pheochromocytoma. Great, great case. Another patient, left upper quadrant pain again. Okay, cystic lesion, thickened wall. What gives you cystic lesions? Metastasis, ACC, pheochromocytoma, a bleed in a lymphangioma or a ganglioneuroma like I showed you, AML which bled, myelolipoma. What could this be? This image doesn't add much, nor does this, but cystic septated. You'd go through a complex cyst that maybe bled. You go through hydatid disease if you're in a crazy part of the world. Not that there's crazy people or crazy parts of the world, but a faraway place from Baltimore, let's say. Well, this was a pheochromocytoma. Pheo is a chameleon, can look like anything, big or small, vascular or hypovascular, solid or cystic. This was cystic. This was a cystic pheochromocytoma. What a great case. Well, I got some more stuff because I don't want to only leave you with adrenal. Maybe I should do that, have a quiz, pick a topic and just stick with it. But all right, pancreas. What are we talking about here? Fever and weight loss. There's a lesion by the tail of the pancreas near the spleen. Maybe it's accessory spleen, I don't know. Here's some more images, a little bit easier to see on these that it's really the tail of the pancreas. And the pancreatic gland shows fatty infiltration. Could this be a Met? Could this be well-defined splenic tissue by the tail of the pancreas? A splenule will be a good thought. It's not perfect because the enhancement is not the same as the spleen, which is typically what we like to see. Could it be a peanut, a pancreatic neuroendocrine tumor that's not very vascular? That's a thought. Here it is on the cinematic. So we have a solid mass, Different texture than the spleen, so I'm sticking away from splenule, but it's a funny lesion. I'm not sure what the heck it is. Well, this was resected. This was lymphoma of the pancreas. Wow. We can see lymphoma involving the pancreas, but usually it's multiple organs, liver, spleen, kidneys, parietic regions, not alone in the pancreas. What a great case. Lymphoblastic lymphoma. Wow. What a case. All right, let me get another case. Chest. Some of you chest people, I don't want to leave you out. Chest pain. What do you got? Anterior mediastinal mass, solid, a little bit of enhancement, eccentric. Kind of looks a little bit like the density and appearance of that adrenal tumor I showed you before. So now you have an anterior mediastinal mass, somewhat vascular. Lymphoma, thymoma, teratoma are all possibilities. Thymoma. This is eccentric. Remember, things that are eccentric, it's not the greatest sign in the world, but you got to think of thymoma. So what could this be? Voila, thymoma. It was a nice thymoma. Again, eccentric, solid, sometimes triangular shape, occasionally calcified. Thymoma is the best answer in this case. What about this next case? And I'll tell you, the patient has mediastinal widening. So there's the image. You have a cystic lesion with what looks like a fluid level, eccentric. Well, let me look at another image. More the same. And let me look at another image that's late. So it's like a cystic thing. Almost looks like maybe hemorrhage layering out. Could be some soft tissue layering out. Could it be a cystic thymoma? That's a possibility, eccentric. Can it be a dermoid tumor? I don't see fat, but dermoid tumor, they also contain calcification, but that would indeed be a possibility. Here it is in the coronal view. I got soft tissue, I got cysts. Again, go for those anterior mediastinal masses. Thymoma, possibility. Lymphoma, I don't like it for that. Thyroid, not connected to the thyroid. There's a thyroid nodule on the left, but that's not it. This is going to be the thing I left out telling you, a teratoma. Teratomas can be cystic, can have this mottled appearance, can be vascular, can have calcifications, all sorts of possibilities, and this indeed was one of them. Okay, what else can I tell you? A cough. Patient has a cough, got a chest CT. Well, the key finding is, I know you have to look at this carefully, but look at the trachea. There's an enhancing lesion posterior to the trachea to the right, and there's the esophagus. Now maybe it's an esophageal tumor. It could be like a leiomyoma, which is enhancing. That's a possibility. Could be substernal thyroid coming down. I didn't give you all the images. That's definitely a possibility. But here now I've given you all the images, so you recognize it's not substernal thyroid. It's a mass 2 centimeter in range, posterior mediastinum. What happens in that location? What lesion is vascular? Yes, you could say Castleman's or Mets from renal cell, but what's classic in that region? You got to think for a second, think a little bit more. Posterior mediastinum can be anterior mediastinum. Good location. This is a good location. Location is everything. We know from property and real estate and from tumors. Good location. What do you think? You're right. Ectopic parathyroid adenoma. Unusual diagnosis, often difficult finding, easy to miss. What else do I got here? Right-sided chest pain. Wait a second. It's a topogram. There's something in the rib here or a chest wall. And here it is. It's the rib. Very dense matrix. What gives you super dense matrix? You kind of run out of things. It's not chondroblastoma. It could be a MET from a blastic tumor, prostate, but it's a funny encasement. What you got to think about here, and the answer is think, osteosarcoma. Well, osteosarcoma, I don't think it's specific. This looks like some type of blastic lesion, but a very heavy response, and osteosarcoma is a great possibility. Let's see. I think I got a few more, and then what I'll do is I'll stop. So let me just go through a couple liver cases. What do you do with this case of jaundice? Dilated ducts, mass centrally in the liver. That's a good question. It's not a pancreatic mass. Hepatoma typically does not occur centrally like that, and surely doesn't cause duct obstruction. You can think of gallbladder cancer can do it, but gallbladder is usually to the right, more eccentric. This is central. Infiltrating tumor centrally, vascular involvement, ductal involvement. Then you have to go think with cholangiocarcinoma. But this wasn't a cholangio. That's what this should have been, a cholangio. This was lymphoma. Lymphoma has so many appearances in the liver, truthfully everywhere. It's so tricky. Infiltrating tumor, encasing vessels and obstructing the duct. I'm going with cholangio every time. You can argue with pathologists here, but you're going to argue in vain. This was lymphoma. What a great case. Let's make this the last case. FUO. Look at the liver. Look right here. With a great imagination, there's something here and on the arterial phase. You can see it sort of, but you see it a lot better on the venous phase. This girl had fever, abdominal pain. She was only from remote to Baltimore, 20 miles, so you weren't thinking of strange things. But she did the foreign travel. This was biopsied because you say it looks like an abscess. Patient was febrile. There's definitely a mass there. Things in younger females, you think about FNH, you think about fibrolamellohepatoma, you think about things that are all vascular. This was isodense, barely seen, low density. It's not good for hepatic adenoma unless it's something that bled. It's surely not good for FNH. What could this be? What could this be? Well, believe it or not, this was biopsied. There it is again. And this ended up being hydatid disease. Wow. Hydatid, usually we don't see much in Baltimore. The ones we see, people have traveled long distances, endemic areas of the world like Mexico. But usually 70-80% have calcifications and 95% have multiple cysts. Solitary, low-density cystic lesion. Oh my goodness, hydatid disease. Hydatid disease, what a great case. All right, I was going to end there, but let me give you a couple pancreases. What do you do with this pancreas case? Cystic lesion, vessels are stretched, maybe duct dilated. You're saying, this is classic carcinoma. But kind of cystic and the vessel is stretched and the vessel is intact. There's the patient's celiac. The GDA and hepatic artery are stretched. And on the venous phase, the lesion is better defined and looks kind of cystic. What gives you cystic lesions? Usually no duct obstruction. Usually the vessels look good or they're hypertrophied and draped over. What do you got then? Well, when you got then, that's when you got serous cystadenoma. Again, a great mimicker. We talk about 3 different types. Oligocystic. We talk about calcification, usually centrally, but not always. Just a really, really great case. Okay, now let me end with one case, which is more of a show and tell. Weight loss, low density mass in the body of the pancreas, dilated duct, transition here. That's a pancreatic cancer. There's no doubt about it. Duct dilatation and duct cutoff. I've told you before, the number one reason people miss pancreatic cancer early is ignoring duct cutoff. But here you have duct cutoff and low density. Changes in texture, which you can see really nicely here. But you can see the duct is irregular on the cinematic rendering. There's the patient's tumor. This is a classic example, don't think too hard, of a carcinoma of the body of the pancreas with obstruction seen. Okay, I got one more for you. Abdominal pain, cystic lesion tail of pancreas, faint calcifications, okay? Almost always, I'm going to say this is a neuroendocrine tumor, peanut, because it has calcification in cystic regions. Calcifications to me are almost always pancreatic masses are neuroendocrine. But I'm telling you, this wasn't neuroendocrine. So now you put your thinking hats on again. Here it is again, cystic calcifications, vessels are displaced. What could this be? I'm running out of time. You're at the jump shot. You're number 23, Michael Jordan. You see the basket. You fake left, you fake right. You scream out, spen tumor, and you're right. Solid papillary epithelial neoplasm of the pancreas. We talk about lesions of the pancreas that calcify. Right up there, neuroendocrine tumor. Peripheral calcifications, MCN in the body, but it's cystic. Punctate calcification, serous cystadenoma. Spen tumors can have peripheral, they can have central. when you see it in the pancreas, you got to think about a SPEN tumor. SPENs are rare, usually young females, but we've seen them in men. We've seen them in older females. Your age of when young is gets older, the older you get, and the tumor seems to be going into older age. With that, I'll stop there. I'll thank you for your attention. It's great to see you guys on YouTube Live, and I hope you have a great day. And with that, ciao, 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 as they would say.